Monitoring vital signs has come up time and time again over the course of the evening, but we'd like to do a bit of a deeper dive on the subject. And to help me do just that, next up I'm joined by a clinical expert who will share his take on how monitoring vital signs can play a role in decoding acute decompensation of compensatory physiology. Ladies and gentlemen, please join me in welcoming on stage a very special guest, Dr. Ashit Hegde, Section Head, General Medicine, Critical Care and HealthCheck Consultant, General Medicine and Critical Care Medicine, D Hinduja National Hospital, Mumbai. Thank you.
Anyway, following Dr. Tabul is a hard act to follow, but and this is, of course, I didn't know this was such an enlightened audience, and my talk is going to be extremely basic. You'll have to put up with me. And actually, I still don't quite understand what this title means, so I just interpreted it in the way I deem fit. Take it or leave it, that's all I can say. Anyway. So this is Niccolo Machiavelli, and he's probably the Italian version of our own Chanakya. So, Chanakya wrote Arthashastra. This book is The Prince, which probably all our politicians must be reading now. It's a treatise on the gaining and keeping of power. And there's a quote from this in Italian from the book, and I'm going to give the translation. As the physicians say, it happens in hectic fever, that in the beginning of the malady, it is easy to cure, but difficult to detect. But in the course of time, not having been either detected or treated in the beginning, it becomes easy to detect, but difficult to cure. So if your vital sign monitoring isn't good enough, there comes a time when even the ward boy will tell you that this patient is critically ill. But that's not when you really want to pick up a critically ill patient. Time is of the essence. So this applies, of course, to all illnesses, but it's very, very important really in the patient who's at risk of deteriorating. And the quicker you identify deterioration, the easier is it for you to prevent further deterioration, the easier it is to treat him. But once it reaches a point where, like I said, even the ward boy knows this patient is in trouble, then obviously most of the time the outcome isn't going to be too great. So, and unfortunately, most of our vital signs, if you look at them, are usually pretty late in the game. I mean, most of the traditional vital signs that we use to detect are pretty late. You know, hypotension. This is because, we all know this is because the body compensates for any usually things go wrong, because I'm talking about hemodynamics. Generally, of course, there is usually, for whatever reason, this is a situation where the decrease in intravascular volume, but it would be cardiogenic shock, it could be any other reason why the cardiac output drops. There are compensatory mechanisms which delay the onset of deterioration in the vital signs, which is why quite often vital signs are not very early indicators of a deteriorating patient, and which is why they fail the way they are nowadays. At least as we follow them today, they're not that great, because compensation takes place, and until the patient really, the disease progresses to an extent that compensation is overwhelmed. And that is too late. You know, picking up things when compensation is overwhelmed, obviously is too late in the game. You need to pick it up much before that, much before the traditional vital signs, fail. So you need to pick up things much faster. So this is one study which showed that, with progressive blood loss, up to almost 1/3 of the plasma volume gone, even then, most of the vital sign hadn't changed, because of this compensatory mechanisms. That's why the vital sign hadn't changed until he lost almost 1/3 of the blood. So, as I said, our vital signs are not smart enough yet, because they've been designed to measure clinical outcomes, variables that are maintained by the body's mechanism to compromise. So, do we have anything more? I mean, I'm really going to talk about some of the things that we could use, which might be better than just a conventional monitoring system. So, first, of course, there's something called the shock index. Shock index traditionally is basically supposed to be better than just your traditional heart rate and blood pressure. Heart rate by systolic blood pressure, if that is supposed to be more than 1, it is supposed to be a better outcome in a patient who is at risk of deterioration compared to the traditional parameters of heart rate and systolic blood pressure alone. Now that has been modified for the age, modified for the mean arterial pressure. So different kinds, variation of shock index. So you have the shock index, you have the modified shock index, you have the age-specific shock index, you have the pediatric shock index. So all of these things have been shown in studies to be better than just the blood pressure or heart rate alone in predicting which are the patients with a likely to deteriorate. So maybe you could pick them up a little earlier in the game, the people who require little closer monitoring. Dr. Tabul already talked about the diastolic shock index. So here, of course, the value would probably be 2 if I'm not wrong, whereas in systolic it's 1. So in patients with shock, it's the other way around, not in hypovolemic patients. It's probably the diastolic shock index, which is probably a little better than these other traditional parameters alone. There's something also now in this thing called the compensatory reserve index. So initially the starting point, obviously your reserve index, you have the capacity to compensate almost fully. But as the disease progresses, your compensation keeps getting overwhelmed till the point that compensation is completely overwhelmed and you have a compensatory reserve almost zero. Initially your compensatory reserve is 100%, but as the illness or whatever is the cause, the hemorrhage or the cardiac shock or whatever else progresses, becomes worse, obviously your compensatory mechanism get overwhelmed till you reach a compensatory reserve index of zero. So there is this thing developed by I think the American Army for trauma, but it has been used in several other situations like obstetric hemorrhage, it has been used in dengue, it has been in cardiac shock, pulmonary embolism. So this is called the compensatory reserve measurement, and that measures what is known as the compensatory reserve index. So basically it's a tool which is capable of capturing all the physiological mechanisms of compensation. So it tries to analyze all the mechanisms involved in compensating for a decreased cardiac output. So this is an algorithm, is basically a machine learning algorithm, and based on, basically analyzes the arterial waveform. This arterial waveform is non-invasive. It's by a device called photoplethysmography, somewhat similar to a pulse oximeter, and it's machine learning. But I mean, obviously they've analyzed several arterial waveforms and come to form machine learning and develop an algorithm to decide which are the patients who are likely to deteriorate. And so this is basically real-time continuous analysis of subtle changes in the waveform, which probably to us we will not be able to recognize, but the machine learning algorithm has recognized these changes in the waveform and has been able to detect what the compensatory reserve index is, and this is supposed to be consistently has been shown to have a higher sensitivity and specificity for predicting the onset of hemodynamic decompensation. So this is probably one more that we might see more of this in the future. It's a pretty simple device. It's just almost like a pulse oximeter, and by, you could probably look at the compensatory reserve index, and which might help you predict who are the patients. And though it was initially applied for trauma, these applications are becoming much more widespread than just trauma alone. Like I said, pulmonary embolism, obstetric hemorrhage, dengue, etc. So that's about one vital sign, but more, I think focus a little more today on the respiratory rate. This is called the forgotten vital sign. I mean, that's probably the most neglected vital sign. We all know, I'm really not going to talk about what affects, several things affect the respiratory rate, starting from the higher centers in the brain, then you have the pontine centers, the medullary respiratory centers, you have centers in the baroreceptors, you have the lung receptors, all of them can affect the respiratory rate and depth of respiration. There are several reasons why respiratory rate goes up, and most of them are usually ominous. Of course, there are certain benign reasons, but most of the time, respiratory rate is a probably ominous sign. And it's arguably the most important vital sign because usually respiratory rate goes up much before the other vital signs decline. So it's actually probably the earliest to be breached. So changes in respiratory rate are often the earliest warning signs of sepsis, shock, respiratory insufficiency, among other things. Definitely respiratory actually increases faster. And numerous trials have demonstrated the prognostic power of respiratory rate in predicting patient deterioration. So in one study, respiratory rate more than 30 was indirectly associated with severe adverse effects, irrespective of the heart rate. In another study, respiratory rate more than 27 is a better predictor of cardiac arrest within 72 hours than heart rate or blood pressure. And in a recent study, that was observed in more than 68,000 patients. When they lower the threshold for deciding when to act or when the patient requires more investigation, more close monitoring, when they lower the respiratory rate to 20, in fact, they were able to save many more lives. So respiratory clearly is a very, very important vital sign, which unfortunately is neglected. Now, this is vital how respiratory rates are monitored in the wards. A nice straight line, complete straight line. So this shows that though it's such an important vital sign, I've just taken a random 3, and I'm sure all of you all will have the same sign in all your wards. Complete straight line. And unfortunately, the problem with NABH is that NABH has a lot of good things to do. There's no question NABH is improved, but the problem is it only focuses on documentation. It does not see how accurate documentation is. As long as we have documented respiratory rate, they don't care whether respiratory documentation is right or wrong. Unfortunately, most of our nurses now, because of requirement document, are spending half the time on documentation rather than actually being at the bedside and monitoring. So, and NABH doesn't care whether your respiratory rate is right or wrong as long as you have written something. So that's the whole problem with the accreditation policy, which probably needs to be changed. So this is just something that I tell my nurse, how has our hospital got an NABH? Anybody, if I was NABH director, I would have, but this is how it is, and I'm sure all of us have the same experience. So that's the whole problem. So So that's what, and respiratory rate is obviously a part of most of the early warning system, is Muse, News, etc. It's part of the early warning system. But if the respiratory rate itself is recorded wrongly, then the whole warning system itself becomes faulty. So like they said, if garbage is in, you're going to get garbage in. If you're going to enter garbage for the warning system, you're going to, obviously the whole warning system is going to become inaccurate. So respiratory rates, so why respiratory, I mean this is all common sense. Obviously usually they're measured by the junior most nurse. Most of the time she doesn't even measure it, but if she does, it's a junior most staff who nurse who's supposed to be measuring respiratory rate. And most of the people, I mean, at least people think pulse and BP is important, but most, not just the nursing staff, I think even doctors think respiratory rate is not that important. They don't give that much importance to respiratory. They give much more importance to pulse and BP. Of course, in that chart, all three were measured wrongly, but at least, certainly, I think of the three, respiratory is the one that is measured the worst. And it's not just the clinicians, hospital decision maker, people who are worried about quality. See, like I said, NABH insists on so many quality parameters and so many other, you need to adhere to so many other things that they spend their time more on all those compliances rather than making. These are the most simple thing to see, whether you need to audit and find out whether your respiratory rate, vital signs are being monitored. And I think nobody does that because NABH doesn't insist on that. That is something that needs to really, again, need to be looked at. So what can we do to improve respiratory acquisition? One, of course, is education. I'm trying to educate all of you all are the lot of leaders in your institutions. Maybe you should go back and try and make things, change a little. I think that is something that we need to be ashamed of, that kind of a chart. Obviously, something like remote monitoring might, make things a little easier, provided, of course, remote monitoring is accurate, shown to be accurate, but that is something that with time definitely will change because it takes a responsibility away from the nurse, a busy nurse already, overworked nurse already, to remote, if that is shown to be accurate. And obviously, you need, like I said, audits, the NABH audit should also not just look at documentation, probably, it will some things look at, whether it is done rightly or not. If not NABH, somebody else just look at that. But there has to be some kind of audit at the process, not just the documentation. That is very, very important. And unfortunately, that is not happening. We are only worried about documentation. We're not worried about whether that is done right or wrong. Like somebody told me, NABH makes bad hospitals better, but it makes good hospitals bad because the good hospitals are now spending a lot of the time in documentation. And this is what actually, it's a controversial statement, but something worth thinking about. And obviously, like I said, you need to engage thought leaders about this thing that. So these are some of the things, of course, you can have remote monitoring, but these are some of the things that probably need to be sorted out before you completely introduce it, before it replaces manual of the nurse handling respiratory. Obviously, the most common thing is that unless the technology is really that good, there's going to be a high rate of false alarms and obviously going to be alarm fatigue and crying wolf and ignoring the true alarms. It can be constrained to the patient. It can increase because there are so many alarms. It can actually increase rather than decrease workload. Again, that's a controversial thing. Whether it's economically feasible, and of course there could be false, or there could be, like I said, false alarms because the respiratory rate might just rise in response to arousal state, physical activity, stress, etc. So this thing still needs to be better, but it's still another possibility. And again, at what respiratory rate would you intervene in a particular patient? Again, the whole idea is obviously you don't want too many alarms. You want to have we are still not sorted out what level of specific. You don't want it to be too sensitive because then you'll have too many false alarms, nor do you want it to be that insensitive because then obviously you're missing the boat. So that's something that needs to be ironed out. Maybe you need to make it personalized for each patient. You need to know what is baseline respiratory rate is and then maybe personalized alarm for each patient because rather than have an absolute set off for 20 or 22, you need to probably have a baseline respiratory rate and then look at trends or personalized each patient. That, of course, I think will happen in the future. Then very briefly about pulse oximetry, I think all of you know about pulse oximetry. There's nothing big. It basically looks upon the different absorption spectrum of reduced hemoglobin and oxyhemoglobin, and it basically emits two waves, infrared and red and infrared waves, and depending on the different absorption, there's a different absorption spectrum and ratio, and that's how you get your pulse oximetry. That's not a big deal. And these are all the limitations of pulse oximetry. Again, this is something that all of you know about. But I'm just going to talk about one thing, that whenever we do pulse oximetry, aim is not just to treat hypoxia. Aim is to pick up deterioration and fall in saturation. Unfortunately, most nurses, most residents like to keep the saturation 100%. They like to give in the saturation drops to 96 or 95. They give enough oxygen to keep the saturation 90%. And we know from the shape of the hemoglobin dissociation curve that once the saturation 100%, you don't know whether the SpO2 is 200 or the PO2 is 200, 300 or 100. And now if somebody's PO2 is 200, the PO2 may drop from 200 to 100, but the SpO2 will still show 100%. So by keeping it 100%, you're going to be delayed. It's quite often post-op patients come to the ICU, everybody's on oxygen, the saturation is 100%. And they might have they may have overdose of fentanyl, they may develop collapse, but because they're on 100% oxygen, because they're on, they're saturated 100%, it's going to take a while for that saturation to drop for the resident or for somebody in the ICU to detect that there has been some problem. So our aim in the ICU is not merely to correct physiology, actually more important is to pick up change in physiology early and intervene to find out the cause of the physiology. Otherwise, I tell people that you can just put everybody on dopamine, give them a blood, give them oxygen, go to sleep. I mean, that's not the idea. You don't want to just have, normal physiology. You need to pick up problems earlier, and that's the whole idea. That is actually, most of ICU work is monitoring, not just treating. I mean, if you're monitored well enough, most of the time you'll be able to prevent what you were supposed to be treating. So I think and that is one thing that I find that I get upset if anybody saturates 100% in my ICU. It has to be 96 or lower. Unfortunately, the moment I go back again, the nurses, residents turn it back to 100. But this is something that is a constant battle, but something that I think we need to think about. And finally, this is something that's going to be talked about in all the talks. I'm really not going to talk about too much about this. This is the integration of wearable technologies, advanced sensor technology. Obviously, all these things are going to happen. Artificial intelligence, because that's going to make a prediction much more easier to predict in a particular patient. Because of machine learning and artificial intelligence, obviously you're going to be able to predict nutrition much better than we are doing now. Telemedicine, all that is going on. Potential impacts, of course, there's going to be probably better outcomes. Obviously, all these needs to be proven. But of course, the challenges that we might have are data privacy and security, how to integrate it with our existing monitoring systems, and obviously the cost, which is always a concern in our country. And finally, I end with what I think is very, very low-tech early warning system. I'm a big believer in allowing free relative access. I allow 24-hour access, and I find that when I go on round, the first thing I ask the patient's relative actually is how the patient is. When I was much younger and much more foolish, maybe I'm still foolish now, but at least when I was younger, I used to disregard either nurses would tell me, no, the patient is fine, this lady is overreacting, she's oversensitive. And invariably the relative was right and the nurse and the doctor was wrong. Vital signs were okay, BP was okay, but the relative said something is wrong with my patient. And invariably, at least not invariably, we had an occasional patient who was hysterical or whatever, but 9 times out of 10, the relative was right and the doctors and the nurses were wrong. So, and that's why my first thing on the round always is to ask the relative, how is your patient? I think at the moment that's a very low tech, but that's probably the most reliable early warning system that thank you.
Thank you so much, Dr. Hegde. And I think what I've really enjoyed about so many of these presentations is while they are heavy on tech, they are just as heavy on the human touch. So once again, I want to applaud everyone in this room for all that you do on a daily basis.